Thanks, Dale. Thanks to the meeting organizers. I've been coming to Ireland for 11 years. This is my first time in Cork, and I look forward to coming back many times in the future and actually meeting with many of you. You've heard a lot today about some of the advances that are frankly happening in oncology, in fact, in rapid order. And one of the technologies that is really sort of transforming in many ways what we do is stereotactic radiosurgery. You're hearing a lot about minimally invasive techniques, and radiosurgery happens to be one of them. So I'm going to talk a little bit about some of the clinical results of stereotactic radiosurgery as a minimally, or I shouldn't say non-invasive, it really is minimally invasive technique that we use to treat a variety of different cancers, and what are some of the opportunities that are there. So this is really an outline of my talk. I'm going to talk about the evolution of the oncologic process, technologies that provide some interesting opportunities for us, and some new models of care, particularly using radiosurgery as a new paradigm in the definitive management of cancers as well as recurrent cancers, and what it takes to do it, and essentially where we're going. So this, to me, is the perspective of a radiation oncologist, and perhaps rooted in our radiological background, is really the oncological continuum of care. What you see across the top is imaging and how imaging has evolved for all specialties in diagnosing cancer. You know, in the early days, we had plain X-rays, and that's what we did, and that complemented what we did with cobalt and perhaps the early days of LINAC-based radiotherapy. And then along came CT and MRI, and then we started in radiation oncology to use those in a more integrated way through the CT simulation process. And as Dale mentioned to you, we have a very strong interest in PET and functional imaging in oncology. In fact, the integrated PET-CT unit was invented in Pittsburgh at the University of Pittsburgh. So we have a long history of thinking about biological imaging and exploiting it in cancer care. Across the bottom here, you can see the development of the radiation technology, from cobalts to linear accelerators to cerebrin blocks to help us shape our fields, to conformal radiotherapy. You all have heard about intensity modulated radiotherapy, and now we're frankly entering the era of biological planning. And with new tracers coming on board, this is really going to change and really drive this concept from diagnostic synergy to treatment synergy to biotechnological synergy. And in fact, today's therapies, whether it's IMRT or radiosurgery, demand more accurate imaging. And what we're really trying to do here is to maximize the therapeutic ratio. It is always a balancing act. There's no such thing as a free lunch. So in this graph, this is a concept of tumor control probability in gold, and the normal tissue complication probability, the probability of us injuring tissue or injuring normal organs, is the challenge that every radiation oncologist, in fact, every clinician struggles with. And what we're trying to do is move that black curve down and to the right, essentially maximizing this therapeutic ratio. And one of the things in technologies that we use now routinely for this is PET-CT simulation. Not just PET-CT, and then you fuse it with your treatment planning, but again, because this technology was invented in Pittsburgh, we actually put our patients in the scanner, in the mobilization devices. You see this is a head and neck cancer patient with a mask in place. And in fact, we've shown that in fact patients who are treated in this fashion, that have their diagnostic images acquired in the treatment planning position, that those patients have fewer recurrences, have greater probability of local control. And recognizing that this is not always possible, but it's certainly something to aspire to. We can then couple that diagnostic technology with radiosurgery. So what is radiosurgery? Just a brief overview here. This is a well-established approach to treat intracranial tumors. We've been doing this since the mid-1950s with Lars Leksell, a Swedish neurosurgeon, considered standard of care for lots of diseases that we treat. It does deliver a high dose of radiotherapy in an ablative fashion in a precise and fairly accurate way. And this is usually done, traditionally it was done in a single fraction, but now we can do it in up to 5 fractions over a week and a half. That was limited to a certain number of diseases intracranially, but now we have the capability of moving extracranially. And with that, you've seen a resurgence, or you've seen an increased uptake of this technology for the treatment of patients with primary and metastatic tumors in the liver, primary lung cancer, and I'm going to make the prediction that within the next certainly 5 years or so, that you'll see that the treatment of early stage lung cancer will be on par, treated with radiosurgery will be on par with surgical resection. I'll say it again. Currently, early stage lung cancer is treated with primary surgery. Within the next 5 years, we have some data already, you'll see that radiosurgery for stage 1 and stage 2 lung cancer will be treated on equal ground, equal footing with stereotactic radiosurgery. Spinal tumors, pancreatic tumors, and an area that's a great passion of mine is recurrent head and neck cancers, which have been proven to be particularly challenging for us, particularly since the vast majority of these patients are not surgical candidates at the time of recurrence. We can actually salvage a fair number of these patients, and I think as you've heard, as we now think about immuno-oncology and immunotherapeutic agents, the combination with radiosurgery, highly focused therapy, may in fact exploit the abscopal effect and in fact increase the outcomes. Prostate cancer, something that we treat for 9 weeks, can now be treated in as few as a week and a half, in as few as 5 treatments instead of 45. And those are some of the areas where radiosurgery really is making a comeback. I'm going to start from the cranial and sort of move through the body, but an area that's particularly controversial, and there's no strong evidence to suggest that it actually works, but I'm going to show you an example, and I think as we gain newer and newer targeted agents, we may have to revisit whether stereotactic radiosurgery, either in the primary or recurrent setting, is valuable in the treatment of glioblastoma multiforme. There's no documented evidence-based approach at the moment, but I can show you, and I have a series of these patients now. Now, not because I have 8 patients that I can show you, does that mean that this is, in fact, the way we ought to be treating this patient? This is a patient who received definitive chemoradiotherapy. Obviously, because of the location of this tumor, this patient is not a surgical candidate, but was treated with chemoradiotherapy. And about 18 months after treatment, patient clearly has a recurrence, as you can see here. There's not very much that we could do for this patient because you're not going to go back and try to resect this if you didn't do it in the first place. So we offered this patient radiosurgery. And as you can see in the second panel on the top, this patient was treated. And if you look, you can see the enhancement is a little more fluffy, so to speak, cotton in appearance. And we weren't really sure what to do, so we placed this patient on vitamin E and Trental and re-imaged that patient a month later. And as you can see through the successive panels is a resolution. Now, what we saw back at 2 months was pseudoprogression, a classic finding in re-radiation, particularly intracranially. And what you see at 15 months is, in fact, gliosis. That's scarring. This patient went on to live for a total of 48 months from this time point, which is absolutely remarkable for GBM. And again, I have a series about 8 of these patients that we have actually salvaged. Now, there's something about these patients that we need to understand. a lot better, but I think there's an opportunity here, particularly with our new agents, to understand what's going on. As I mentioned earlier, early stage lung cancer is an area where I think we're going to completely change the paradigm of what we've done. On the left-hand side of this of your screen, you can see what we did for decades, conventional radiotherapy, APPA, for this lung cancer that you can see here, treating the mediastinum, the hilum, and the tumor itself. A lot of normal lung in that volume. And then along came 3D conformal therapy, and we tried to shape the beam a little bit more. And now we have IMRT, but we just didn't stand there, right? We went on to look at 4D PET, because these things are, in fact, living, breathing organisms. We're not treating an image on a page, understanding what exactly, and the motion dynamics of the tumor inside the body allows us to deliver highly focused radiation and ablate these tumors while sparing normal tissues. So 4D CT, four-dimensional, the fourth dimension being time, we now have the opportunity to actually see the characteristic motion of these tumors. We can shape our radiosurgery beams and destroy the tumors themselves without causing a lot of harm or toxicity to the normal lung, the esophagus, heart, and nearby critical structures. And this is a perfect example of what exactly this technology is and how we use it. So the conventional image is the image on the top left. You can see there's scalloping and there's some artifacts, and you can look at the actual volume of the tumor that's drawn by a radiation oncologist, and you can see it's fairly large compared to a gated image. A gated image is closer to reality, is in fact stopping the tumor, because we understand the motion pathway of the tumor, we can actually draw it better. If we know what the tumor is doing inside the body, we can gate our beam, turn the beam on and off, depending on where in the respiratory cycle that tumor is, and in doing so, deliver these highly conformal radiation treatments. And just to show you what a field would look like, on the left, you see a non-gated field. It's a fairly large volume compared to the field on the right, which is about 60% smaller if you look at it in 3D. And that has significant implications for the therapies that we deliver. And in fact, this is a graphical representation of how this radiation, how this gated radiation therapy works, tracking the tumors inside the body, and in fact delivering it with an arc-based therapy in a fraction of the time that we would in the past. So if you take a look at the outcomes, what you can see here is the 3- and 5-year outcomes. One is in blue is the local control rates and overall survival rates for these patients treated with early stage lung cancer. And there is a certain dose that you need to get to achieve these outcomes. But when you think about it, compared to conventional treatment for these patients, these local control rates are at least 40 to 50% higher than we normally would see. So again, I think we have an opportunity here for appropriately staged, early stage lung cancer to treat them in a way that preserves their function and maximizes their opportunity for local control and for cure. And this panel just shows you using a PET-CT-based approach, monitoring the patient. In the first panel is pre-treatment. The second panel is 1 month after treatment, which I would not recommend you do as a PET-CT. Usually it's 8 to 12 weeks after treatment, but in the early days we were looking at the response. And what you can see at 3 months in panel 3 and 8 months is a complete resolution of the PET avidity and no development of new disease. In fact, we have data now that tells us that it can predict, based on the PET response, those patients who are likely to ultimately have local control, but more importantly, who are the patients that are likely to fail your therapy. So for those patients in this data set where there are 2 that had progression at the treatment site, you can see here that they had a change of 32%, 34% in their absolute SUV change at the 3-month mark, and that basically tells us those patients are ultimately going to fail. So the pre-treatment and post-treatment delta really predicts our response. I'm just going to keep moving here. But this is not without risks, right? There are toxicities associated to tumors that are in the central bronchial tree, and so we learned very early on to protect and to choose our radiation techniques based on the location of these tumors. I'm going to jump through these. So clearly some of the benefits of radiosurgery for early stage lung cancer, there are usually 3 to 4 to 5 treatments over about a week and a half. There's preservation of lung function. You have the ability to deliver a higher, more biologically effective dose, and clearly the control rates are significantly higher compared to conventional external beam, which is delivered over a 6 to 7 week period. There's a significant amount of pulmonary fibrosis, and because there's usually a fair amount of lung involved, there's some limitations in terms of the dose that you can achieve, and you can see the local control rates there range from 30 to 70%, even in early, and this is specifically early stage lung cancer. So what about head and neck cancers, just moving down the pike? This is an area that, again, is a great passion of mine. We recognize that 60% of our head and neck cancer patients, despite our aggressive surgical resection, chemoradiotherapy, will fail local regionally. And if the disease is truly local regionally, we have an opportunity, we believe, to salvage those patients. And again, what we use is PET-CT to help us, because seeing truly is believing. So if you look at this panel here, you can see that there's an abnormality in sort of zone 1, zone 2 of the neck. You can see the obvious abnormality on the PET, but you see a lot more with the PET-CT. Now, the challenge comes is after treatment, when you look at the CT, there's still a bit of an abnormality there. So did this patient have a partial response or a complete response? In fact, if you look at the PET, this patient, in fact, had a complete response and therefore no need for additional intervention. We've seen this in a number of other disease sites where we've been able to avoid unnecessary intervention based on an assessment of response with PET-CT. So PET-CT is, in my view, invaluable, particularly when you're doing recurrent head and neck disease evaluation. And in fact, we've shown that a higher dose of radiation, not surprisingly, and that's up to 10 gray per fraction in 5 fractions over about 10 to 14 days, which is contrary to what we've been taught conventionally, historically, works. It's not hyperfractionation, it's hypofractionation. And highly conformal doses, in fact, is important. In fact, we've now developed a nomogram, it's the only one in the literature, that I basically can look at the volume of the tumor, the dose that I've selected, and predict the 1, 2, and 3-year probability of local control. In this case, 83% for this tumor that is 40 cc's. In fact, we've compared IMRT re-radiation with radiosurgery, and we've discovered through this multivariate analysis that there is no difference in outcomes if you use IMRT versus radiosurgery, with the concept that you have fewer toxicities and, in fact, greater compliance. And so at our institution, we pretty much are using radiosurgery for recurrent head and neck cancers. We've also been able to determine that the patient-reported, not physician-reported, but patient-reported quality of life is, in fact, improved successively in patients after being treated with radiosurgery. So it's not just a clinical outcome, it's also looking at the patient-reported quality of life measures. And to quickly look at lung cancer, at pancreatic cancers and liver tumors here, and I use a patient as an example. 40-year-old female, metastatic breast cancer, presented with 9 out of 10 pain, was on narcotics and nausea. We did a PET-CT SIM for her and did stereotactic radiosurgery. And here is the tumor based on the CT and the PET-CT. We created a radiosurgical plan for her, 45 gray in 3 fractions, and made sure that we protected the duodenum and the non-involved liver. And what you can see here is the complete response. Now, radiographically, there's still an abnormality, but this tumor is actually went on to be controlled. You can see that she developed other lesions. But remember, she came to us with 9 out of 10 pain, narcotics. She was a former nurse and non-functional. So we were able to get her out of her pain and get her on to other systemic therapies. And the data basically shows us that we can get significant local regional control, 95%, 92%, 17-month median survivals in these patients that we treat. For pancreatic cancers, and I'm mindful of my time here, I'll just move along. We typically use CT-based treatment planning, but if you incorporate the PET, you can see the tumor better. But if we take it one step further and mobilize it with 4D CT, which you see on the lower left, you now have a sense as to what the tumor is doing inside the patient. But taking it one step further, where you have 4D PET CT, now you can see, and seeing truly is believing, you can see some characteristics of the tumor. There's a lymph node here that you didn't appreciate in the 3D PET CT, and also the center of that tumor is not taking up a lot of FDG, which probably means it's more radio-resistant. We can create a radiosurgical plan and treat the patient, and what you see post-treatment is still there's a radiographic abnormality in the region, and you think, well, you had a partial response, much like I showed you in the head, neck, and the liver case. But if you look at the PET, it is actually a complete response. What you see there is minimal residual inflammation related to radiotherapy. This patient went on to live 48 months and did not require immediately additional therapy, because if you look at the CT, you would say this patient had failed that therapy. Another area of interest of ours is spinal radiosurgery. These patients who have received external beam for a metastasis to the spine and then had recurrent pain. And so what we have been able to do through a prospective study looking at over 500 patients with disease involving multiple levels of the spine, that we were able to, in fact, improve pain in 86% of these patients, had long-term local control at that site in 90% of patients, and the vast majority of patients, 84%, had improvement in their neurologic function. So this is sort of represented here graphically, showing that, in fact, for these patients who sometimes can have intractable pain, we can actually do something about them, return them to their baseline quality of life, and in some instances, improvement in their quality of life. But all this technology requires a lot of training. This is not an out-of-the-box technology. And so because it requires high definition, target definition, precise target definition, I think I've hopefully made the case that you need multimodality imaging, not just CT-based. It may be MRI, maybe MRS, maybe PET CT. We need to understand organ motion. Because we're using smaller and tinier margins to protect the normal and critical structures, you really need that advanced imaging and understanding where the organs at risk are, and updating our constraints. And so a lot of the machinery that you see in radiation now and that you're going to see here at the Bon Secours will have advanced imaging, again, with the idea that we're going to deliver these highly precise radiation treatments and minimize the toxicity to our patients. So the challenges, as I said earlier, are target definition, organ motion, and assessment of response, which we showed you a bit earlier. So in conclusion, I hope I've convinced you and shared with you my vision of where we're going and of radiation oncology, specifically around radiosurgery, that is in fact safe and effective. We're now rethinking the traditional models of radiation therapy, that we can provide shorter courses that are more effective. We have greater compliance, because if you can deliver the entire course of radiation treatment in a week or 2 weeks or 3 weeks instead of 9 weeks, that patient's likely to come for all of the treatments. And in fact, for patients who are poor surgical candidates, we now have a minimally invasive approach for lots of tumors, in fact, that may in fact offer us an opportunity to improve the outcome of our patients. So what are some of the next steps? As we mentioned earlier, I think the exciting thing for us is that we now have an opportunity to exploit the immune response. Radiation therapy is highly immunogenic. And in fact, there's an obvious synergy that's here that really will extend beyond the primary treatment of tumors to perhaps treating patients who have oligometastases, not necessarily treating all the lesions in the body, but only a few of them, enhancing the immune response to these tumors. There's some further refinement around radiosurgical techniques that you'll see coming down the pike, including some technologies that will have the tumor literally call in the radiation strikes rather than the radiation oncologist directing the radiation to the tumor. And we'll talk about that at some other point. And so, as I said earlier, there are some really exciting new PET-CT tracers that are coming down the pike that are tumor-specific that will, in fact, enhance what we do. It's been a pleasure talking to you about radiosurgery, my vision of what we're going, and the opportunity that we have here in Cork is really exciting, and I thank you for your attention.
I think we have a minute or two for any questions that might be referable to Dwight.
Thank you very much. Thank you very much. That was an outstanding talk. Do you think that we need to have a PET, or at least the ability to put a PET into our unit if we're going to stay current?
I think we need to have the capability of PET-CT treatment planning. I know there's been some discussion, and I think it really is important that, one, I recognize that there's a slightly different reimbursement environment, and in fact, we need to understand how to use PET, not only in diagnosis, but assessment of response. You can't do it, be doing it every 2 or 3 months. But I think for the oncology program here, we need to look at how we can access PET, because I think it's really, really important in the management of our patients. I know when we build these systems, we usually bill our PET-CT simulator rooms, or CT simulator rooms, with PET-CT upgradability in mind. But again, that's a discussion to have with members of the hospital in terms of how can we access PET capability, whether it's in the hospital or in the unit itself. Great question.
Thanks very much for the talk, Dwight. It's very interesting. I'm just wondering whether you think there'd be any benefit in PET simulation for other types of external beam other than radiosurgery. And also, do you find with the PET simulation that you're having to increase your tumor volumes because you're seeing kind of growth of tumor on the PET that you wouldn't have seen otherwise on the CT?
That's an excellent question. So yes, so the PET-CT is not used, and perhaps I didn't make that clear, my apologies, just for radiosurgical planning. It's even more important in radiosurgical planning because especially if the patient's had radiation before, there may be scar tissue and maybe they had surgery before, so it's sometimes difficult to actually see the tumor precisely. So PET is invaluable in those circumstances. But we use PET for treatment planning in definitive cervical cancer, in head and neck cancer. We use it in some brain tumors. We use it in esophageal cancers, a variety of different cancers, rectal cancers. So it's not just radiosurgery, it's conventional. That was the first part of the question. What was the second part of the question?
Just whether you found that tumor volumes were slightly
Yes.
larger.
So that's the incredible value of PET, right? Because it also allows you to identify patients who are the appropriate candidates for therapy. So if I'm going to treat an early stage lung cancer that I think is an early stage lung cancer, I sometimes can find disease elsewhere that I wouldn't have seen on CT alone. And then that means the therapy that I was going to give them, a very local therapy, would have been an inappropriate therapy for them. So there are some patients, about a third of patients, who will get upstaged by PET, but there are also patients who will get downstage, an equal number. And in fact, in both circumstances, I think that's valuable because we don't then deliver ineffective therapy for inappropriate therapies for patients. So absolutely right, yeah. So I would advocate for PET-CT for a variety of diseases, not all of them, simulation up front.